you need to have updated version of the Zoom. If your Zoom is not updated, please update your Zoom in order to benefit from interpretation services. Now we can start with the program. Esteemed President, Mr. Chair, and dear participants and dear colleagues, first of all, I would like to greet you all with my respect on behalf of WHO, and I would like to welcome you all to the symposium on NCDs management among refugees and migrants. First of all, we are really pleased to be here together with you in order to discuss this issue. As you all know, we have 70% of mortality related to the diseases such as cardiovascular diseases, cancer, chronic respiratory disease, diabetes, and in addition, we have more than 82% of all NCD deaths together with all other diseases. However, these can be a burden on the health system as well. And also, non-communicable disease can decrease the basic factors and they can be preventable. And also they are also cost effective. In case of emergency, first of all, the priority is to minimize the mortality as far as possible and to address the most urgent needs. However, in some cases, we need to have the preventive activities and we need to have a strong focus on them. Today, we are going to have great contributions from our colleagues and dear speakers, and we are going to discuss this management for NCDs. And also, I would like to say welcome, and I would like to give floor to Dr. Batici to floor. And I would like to give first floor to Dr. Batici. And we have the interpretation, English and Turkish. If you would like to listen from the interpretation, you can choose the language. Now the floor is yours, sir, Dr. Batir.
Let me check the equipment. Can you hear me?
Evet, sesiniz geliyor net bir şekilde.
Thank you.
Yes, we can hear you.
Thank you very much. Distinguished representatives of the Ministry of Health of Turkey, the Dr. Kanuni Keklik, Dr. Banu Ekinci, representatives of the donor KfW Development Bank, Ms. Sonia Wasserman, esteemed UN colleagues, dear participants. It's an honor for me to welcome you to the symposium on non-communicable diseases management among refugees and migrants. This event is happening thanks to our close collaboration with the Ministry of Health of Turkey and the generous financial support of the KfW Development Bank, for which I would like to thank sincerely. This is also a special event for me, as it's the first symposium and a public event I am attending since I started working as a WHO representative in Turkey, starting from last week. And it's a great privilege and honor for me, and I'm looking forward to our close collaboration with all of you. So welcome and merhaba. It is probably needless to remind, as my colleague Melda already mentioned, that non-communicable diseases are the greatest contributor to mortality and morbidity globally. And in contrast to the COVID-19 epidemic we are living through, the pandemic of non-communicable diseases, it's a slow, protracted pandemic requiring a global multi-sectoral response and a strong national and international leadership. The burden of non-communicable diseases among refugees and migrants is an increasing and widely recognized problem. And it is actually reflected in the WHO European Region Strategy and Action Plan for Refugees and Migrant Health. It is well known that Turkey is hosting the largest population of Syrian refugees, more than 3.6 million, providing protection and care for them. And this is a strong demonstration of international solidarity and responsibility. Syrian refugees have an access to the health facilities, including through the refugee health centers, where they can access services without cultural and language barriers. WHO Refugee Health Program, run by country office here in Ankara, supporting the efforts of the Ministry of Health in this context. Today, we will be presented the results of the study, Training Needs Assessment for Non-Communicable Disease Management in Refugee Health Centers in Turkey. And I would really like to emphasize the importance of the assessment, which will enlighten the area which needs to be improved for NCD management in the refugee context. As we know, in these days, the refugee and migrants with non-communicable diseases are one of the vulnerable groups who need special attention. And WHO will continue its efforts to promote health, keep the world safe, and serve the vulnerable. I would like again to thank the government of Turkey, our donors, and all the partners for the close collaboration, and thank you for participation in today's symposium. Let me wish all of you a very productive and interesting event. Thank you.
Doktor Batir Bey'e açılış konuşmaları için çok teşekkür ediyoruz.
We would like to thank Dr. Batir for this opening speech, and we are going to benefit from his experiences in the future. And in Turkey, of course, the training of the Syrian health workers and also providing services at home in terms of health are essential. And we have been working together with the fund provider, KFW. And now I would like to give the floor to Sonia Wasserman, the portfolio manager from KFW Development Bank. The floor is yours, madam.
Thank you very much. I hope you can hear me. So, dear colleagues from WHO, esteemed partners from Ministry of Health, thank you very much for inviting me to say a few introductory words. I send my warm regards from Germany. We are the German Development Bank, and I have the honor to say these introductory words because this study was conducted in the context of our joint cooperation with WHO. We have been cooperating since 2018, and we have a very successful joint program which tries to improve service delivery and accessibility to healthcare for refugees, and on the other hand also tries to create employment, especially for Syrian refugees, in order to sustain their livelihoods. The program is implemented in very close cooperation with the Ministry of Health, so we very much value this very close cooperation, and it's implemented jointly with several implementing partners. So you all know, you work in the health sector, so you're very well aware that at the moment the health sector is very much in the focus of international and also national attention, but you also know that this focus is very narrow, right? It's very much focused on COVID-19, on daily cases, on treatment options, on treatment capacities in the hospitals. But this very narrow focus may threaten the achievements that were made in other areas of health, in the prevention and treatment of, let's say, normal diseases like the NCDs. So it's actually a danger that it has very negative consequences for the health sector overall. So we very much appreciate that WHO has now taken up this opportunity to discuss the findings of the study that was conducted about the NCDs, and yes, to go into discussions with all of you, with all of the participants, and try to find ways how to improve the service deliveries for the NCDs during these pandemic times. So yes, I wish you the same. I hope it's going to be a very interesting and productive meeting. I'm also very interested to learn more about the situation in Turkey. And yes, thank you very much for inviting me.
Sonya Hanım'a güzel sözleri ve desteği için tekrar teşekkür ederiz.
We would like to thank Ms. Sonia for those nice words. Now, once again, for the fund provider, we would like to thank KfW Development Bank once again. Thank you. Now, I would like to give floor to the head of Department of Migration and Health, Public Health Directorate General of Ministry of Health of Turkey, Dr. Kan Keklik. The floor is yours, sir. First of all, I would like to welcome you all and greet you all. And once again, I would like to say welcome, Dr. Batir, at your new position. I hope we will be in cooperation together with the health services of the migrants and refugees. And of course, this is a very important issue, and I don't want to make a technical explanation because this is the introduction part. We have colleagues, we have professionals, we have the results of the researchers. For this reason, the relevant departments will share all these data appropriately. For this reason, I would like to focus generally how do we proceed in terms of non-communicable diseases management for refugees and migrants in Turkey? As you all know, we have more than 3.6 million of Syrian refugees. Of course, we have the refugees and the migrants, but you know, we focus generally on this number, 3.6 most of the time. And we have 3.6 million, and we started accepting them as of 2011, and we have our guests in 81 province of the country. As you can see in the government of Turkey, of course, we try to provide all the services in the best manner, and especially for healthcare services, we try to provide all those services and we try to implement all of the practices. And of course, we have international cooperation and we receive international and national support like WHO and others. That's why I would like to thank all of those stakeholders as well. Of course, this number is really high, 3.6. And of course, we are going to share all those numbers at the end of September once again, and then you're going to have the opportunity to see the general picture. And as of the end of September, I can share the data as we have 77 million of physical examination in our hospitals at primary healthcare services as of 2011. And 11 million of them is in 2020 due to the negative effects of pandemic. So we can see that we have devoted healthcare workers working devotedly, and we have hospitalized healthcare services more than 200,000. We also provided the delivery of more than 615,000 of Syrian babies. So also the vaccination, they are all followed in national immunization program. We all applied this program to the Syrians. We have more than 7 million. So generally, I can tell you all the services are provided in a very comprehensive manner. On the other hand, we try to improve our services and we try to provide all those services internally. But of course, there is the language barrier and also there could be some disadvantages. That's why we have conducted a project together with WHO, and we also combined it together with the European Union project, which is named SIHAT. So we try to improve our services. And now we have refugee health centers in more than 29 provinces, and we can have the internal medicine, psychologists, psychiatrists, social workers. So we can have these units, these centers together with all those professionals. And moreover, we are going to improve all these services, and we can see refugees can benefit from all these services when we examine the figures of 2020. And More than 50% of the physical examinations have been performed in those centers, and I believe this is something positive. And as Ms. Sonia stated, we focus on COVID-19. Of course, this is something inevitable. And for the services related to non-communicable diseases, we pay more attention to COVID-19. For this reason, we are aware of the situation and we try to pay more attention to some other situations. Of course, we shouldn't skip the current situation, but we try to evaluate, we try to make different analysis. I'm sure all these results will be shared by our colleagues, and all these results will be examined, and we have the guests under temporary protection.
Merkezlerinde hizmet sunan sağlık personelinin konu hakkındaki farkındalığı.
About the health personnel providing health services, there's a need for raising awareness among them, and in this scope, there's a need for enhancement of the management. And taking this opportunity, we are going to evaluate these results all together, and especially with the support of the bank, in particular in the services, health services for the migrants, we are going to structure it in the best way possible. As shared, the combat against chronic diseases is not something that can be coped with the health sector only. This is multifactorial, multi-stakeholder phenomenon, and taking this opportunity, this side will also be enhanced. This aspect should be strengthened as well. I do not want to talk too long. I would like to thank to all professors, WHO, German Development Bank, and my colleagues for contribution to this work. And I would like to thank all of the valuable employees, staff of the WHO. And I hope we are going to be all together in better works. And I wish you all a nice day. Thank you very much, Dr. Kanuni, for your opening speech. As you have expressed, so far we have carried out a lot of projects, and we have witnessed that these projects have been touching the lives of people, and our collaboration will continue. Now, I would like to leave the floor to someone for whom we are very happy to be together with, a worldwide important expert about the migrant health, and also she is the author of the one of the authors of the guideline of prevention of NCDs. So I would like to leave the floor to Professor Bernadette Kumar. I would like to remind you that we have interpretation service. Ms. Bernadette, the floor is yours, and I would like to thank you in advance.
Good afternoon, everybody. I'd first like to say a great thank you to the organizers for inviting me to give this keynote address. I'd also like to say a particularly thank you to officials from the Ministry of Health in Turkey, WHO in Turkey, donors, and others. So, respected WHO representative, respected officials from the Ministry of Health, and dear colleagues. I'm going to take you through prevention and control of NCDs among migrants and refugees, and this is going to be an overview for the later panels and discussions that are going to take place later in the afternoon. And I think the WHO rep already talked about this, but basically it's a public health emergency in slow motion. I'd also like to acknowledge colleagues, Dr. Santino Severoni, Dr. Joseph Bartovic, and also a colleague from Turkey, whose data, Dr. Mehet Palster, I'm going to be showing you. So it's a very large topic, and I'm not sure that I'll be able to cover everything, but I'm going to talk about a little bit about migration health, the evidence overview, the rationale for prevention, the guideline, the technical guidance that we have, the overview of that, and some recommendations for policy at the end of it. So if we look at NCDs and migration health, it's an important area that is intersecting two rapidly growing areas of concern. NCDs, we know, non-communicable diseases, are responsible for morbidity and mortality, both in high-income countries as well as in low-income countries. And the figures speak for themselves. Migrant health is also an area of an issue, a defining issue of our times, because there's over 1 billion people with migrant history, not just that they're migrants, but they've been have a migrant history at some time or the other. Of these, over 250 million are international migrants, and we have about 90 million in Europe. So these are considerable sizes. And the area that I showed you often falls between NCD and migrant health and can be a challenge to address. So what is the relevance first of migration to public health? We know that migration health has become an essential part of public health, not only because of the numbers and the large numbers, but also because of the implications in terms of long-term globalization and unequal development patterns. There's forced migration that we all are witness to as a result of conflict and war, natural or man-made disaster, financial crisis, climate changes, etc. And the health of migrants and health matters associated with migration are crucial public health challenges faced by governments and societies. Many countries are well prepared, but need urgent coordinated response to address the short-term and the long-term implications, including NCDs, and I'll come back to that. Health systems in receiving countries need to ensure health services access for migrating populations in order to protect and promote their health. We therefore cannot separate the health of migrants. And when I talk about migrants, I'll come back to the term in a while. I'm talking about all types of migrants from the health of the rest of the population. So who are we talking about? And we can talk about regular migrants, asylum seekers, refugees, economic migrants, irregular migrants. And there are many definitions, but at the end of the day, despite the definitions, we are talking about people. And that's the most important thing to remember, regardless of which category and definition they fall under. The health issues that often stem related to migration are issues related to health risk assessment, exposure to hazards that are different for migrant communities and compared to resident communities. The state of health of migrants that changes the profile, chronic disease and NCDs, re-emerging neglected disease, the health system capacity and economic impact of actually delivering when it comes to these changes, migration policy and integration, access to health services and overcoming health system barriers, as well as the big challenge of public health data collection and generation. And I'm very pleased that today some of this data will be presented at this symposium. So if we look at migration, it's like a bridge to global health, and you have countries of origin and you have countries of destination. And you can see that the arrow is going in both directions when it comes to disease burden, health risks, health behaviors and beliefs, health infrastructure, others. And in some cases, it's in a positive direction. Sometimes it's in a negative direction. But this direction changes depending on the countries of origin to the countries of destination and the different groups of migrants. When we look at NCDs, NCDs are already the leading causes of death and disability, responsible for 70% of deaths. And when we talk about NCDs, it's good to just remind ourselves that what we're talking about is cardiovascular disease, diabetes, cancer, and chronic respiratory disease. And they impose a major challenge when it comes to health and development in many countries. And their prevalence rates are actually much higher in low and middle income countries. And when we see the situation, as I mentioned before, of forced migration, whether it's armed conflict or it's related to climate change or other situations of violence that drives people from their homes, those groups and those subgroups are more vulnerable to the stresses of migration and the severe conditions on migrants' routes and with regard to regular access of healthcare. And here you can see the WHO map, which shows the global status report on non-communicable diseases, which is the probability of dying from the 4 main non-communicable diseases. And we'll go into that a bit later. So we know that when we talk about these non-communicable diseases, I've already talked a little bit about the diseases. The risk factors are also very well known. There are the underlying risk factors, and the risk factors are actually divided into lifestyle factors and metabolic factors, metabolic risk factors. And if we look at lifestyle risk factors, we have what we call the usual suspects. That's diet, physical activity, alcohol, smoking. And then you have obesity, high blood pressure, hyperlipidemia, etc. That are the metabolic risk factors. And one other thing I'd like to draw your attention to is we have these 4 conditions that we include under non-communicable diseases, but we also see in the older population and often also in migrants, multimorbidity, that is more than one condition can occur. And of course, that the outcome that we're very concerned about is mortality. So the rationale for why we're looking at NCDs and migrant health together. And it's a colleague, a GP from Canada called Nicole Nitti, who actually put it very succinctly across and said, when I began to work with migrants and refugees in Toronto, I excitedly began reading up on tropical medicine and communicable diseases, even bought a textbook and a handbook. Months later, the book was gathering dust. And my appointment slots were filled with people struggling with diabetes, hypertension, or other chronic diseases. Many of them had inadequate understanding of their conditions and how their long-term health may be affected. And this was when she said she really wanted to improve the health of the clients, and therefore needed a new approach to the disease prevalence that is rising all over the world. Because very often this is thought of, NCDs are thought to be an issue related to high-income countries, but that is really not the condition. So the WHO Europe therefore commissioned the technical guidance that looked at summarizing the literature that was available, what needed to be done, to look at what were the tools and guidelines available so as to promote further evidence-based policies and interventions that would contribute to the reduction in morbidity and mortality from non-communicable diseases in the migrant population. And before we leave this part of the keynote, I'd like to say that this is a very important slide that shows that everything of reaching ill health. You have specific mediating processes, or you have exclusionary processes like discrimination, socioeconomic factors like poverty, and then you have nutrition, physical activity, all the risk factors that we know of. And how these factors act in concert with each other or in parallel processes for different migrant groups also varies. So how did we, this is the technical guidance, and I see that in the invitation, all of you have links to the technical guidance, so you will be able to go back and refer to it. What we did was we did a scoping review of literature. There was, 8 systematic reviews included and 111 studies on NCDs in Europe. The desk review of grey literature was also done, and we looked at both fields of migration health and NCDs to extract already identified evidence-based policies and existing recommendations. We also had an expert group that then discussed this and discussed the findings and also discussed the policy recommendations that came out of it. So very quickly, why should one bother about NCDs in migrant and ethnic minority populations and refugees? So NCDs are a significant contributor, as we've already established, to mortality and morbidity, and including the migrant population. The other reason that is very important is NCDs are preventable. 80% of premature heart disease, stroke, and diabetes is preventable. We also know that the cost of the treatment and management and compliance to treatment of chronic disease, the very fact that it's chronic means it lasts over a long time, is very expensive. And that is a reason why we would like to prevent it, not just the cost, but also the cost it has to the individual and their families of living with chronic disease. And we know that refugees and migrants in the WHO European region often have a higher rate of heart attack and of stroke than local born populations, attributable to both migration-related factors and socioeconomic factors. We also know that the same group, refugees and migrants, have higher incidence, prevalence, and mortality for diabetes than the majority population in the region. And particularly some groups like those from South Asia have been studied more in detail than other ethnic groups. And we also know that we can do something about the key modifiable metabolic and behavioral risk factors, like the use of tobacco, unhealthy diets, physical inactivity, harmful consumption of alcohol, overweight, obesity, hyperglycemia, hyperlipidemia, and high cholesterol, high blood pressure and high cholesterol. And when we look at the studies that are available, and this is a very important study that came out in 2016, it's a bibliometric analysis of global migration health research in peer-reviewed literature, and they went through 25,000 studies. And you can see there that a lot of the studies focused on acculturation, poverty, mental health, but you have to really look for issues of chronic diseases over there, diabetes mellitus is there. So we don't have, in a nutshell, enough data on issues on NCDs. And it is really, and when you look at the NCD data, you have a lot of data on NCDs, but it is not disaggregated, and you don't know anything about the migrant group in that. So in both areas, we are lacking data. But it's not as if we don't know anything. And that's very important. The studies that we have are largely descriptive studies. We know that migrants are vulnerable to NCDs, and there's an increasing burden of non-communicable diseases among migrants. And one of the reasons why this happens is because what you might see in a generation, in the majority population, with migrants, the process of acculturation, the process of migration actually hastens a lot of the development, hastens changes in diet, changes in physical activity, changes in lifestyle, etc. And so one sees that they develop NCDs much earlier. And migrants may have additional health risks due to interruption of care for NCDs because of the fact that they're on movement. And healthcare provision to newly arrived migrants is often inadequate because one assumes that the newly arrived migrants are healthy migrants, and very often they are, or the fact that they have other issues like communicable diseases, or of course, the old stereotyping that migrants have exotic diseases and they're not really at risk for NCDs. And then you have that the Eastern paradigms of health and illness may conflict with Western medical recommendations. Migrants don't often understand the concept of chronicity. The nihilistic attitudes towards life undermines attempt to encourage healthy living. So there's a lot of other things that need to be explored. And then you have the socio-economic determinants, in addition to the migrant status, that we know there's an association between the socioeconomic status and development of chronic disease. And so migrants have a double jeopardy in that they often have both. So we do know we do know some things about NCDs and migrants. But what we don't know is because of the data challenges. We have a lot of data challenges. There's very little routine data. It's insufficient, it's inadequate. A lot of it is ad hoc. Migrant status is often not registered. Refugees are missed out or not included in studies. There are very few population-based or epidemiological studies. Clinical data is limited regarding the prevalence of disease. Very little attention is given for determinants. So even though we might know the prevalence of diabetes or hypertension or chronic respiratory disease, we really don't know a lot about determinants. We have very few, if none, longitudinal studies. We really don't know what works for migrants because there are very few effective preventive intervention studies. Longitudinal studies, as I mentioned, incorporating various comparisons over a period of time with a focus on the cause of the causes are very limited, and we haven't found many of those studies. Studies that evaluate policies addressing causes of causes, for example, integration policies, socioeconomic measures, food policies, improvement in terms of environment, in terms of housing. Very few studies that actually take into account all of that. So though there is knowledge about NCDs and migrants, I would say that the current knowledge produced is not sufficient to facilitate policy making, closing the policy practice gap. This is thanks to my colleague in Turkey, and we presented this last year at the WHO Summer School, which was in Turkey. So I would like to acknowledge again that there are 3 health surveys that were done among Syrian refugees in Turkey. And many of you might know this data and are familiar with it and better than me. So I'm not going to claim to know everything about these studies, but just saying that the studies that have been done, if we look at, this is where they were done, and I'm just going to take you very, very quickly through some major findings that really touch exactly on these issues. And if you look at the Syrians in Turkey and the Syrian refugee population in Turkey, you will see that the tobacco use, and this is the Syrians in Jordan, is higher than the Turkish population, except in the women here. And when you look at both groups, you see that it is still quite high compared to what we would like to have. And if you look at physical inactivity, the proportion with high levels of physical activity, here again, compared to the majority Turkish population, we see a higher proportion of physical inactivity. And if we look at obesity, we see here there are not many significant differences between the Turkish population and the Syrian population in Turkey. Similarly, we see for high blood pressure, but in both populations, there is more than 25% of the population, 1/4 of the population, that has a high proportion for increased with high blood pressure or on medication for high blood pressure. If we look at diabetes, here again we see that the prevalence for diabetes is much lower compared to, for example, high blood pressure or hypertension. But here again we see that there are differences between men and women, and we see that some among the men was a higher proportion among the Syrians in Turkey. And if we look at CVD, again, we see that among the Syrian population in Turkey, they had a higher proportion than the Turkish population. And just to summarize, this was just to give you a bird's eye view, and I'm sure you have other data that's available in the country, but it was saying that it just documents the fact that NCDs are also prevalent among refugee and migrant populations. And we see that very clearly, that here we see that nearly 60% of men and 56% of women have 3 to 5 risk factors. So it's very clear that this is not something that can be ignored. It is something that requires action. So why should we address NCDs among migrants? The first argument, I would say, is always the rights argument, because the right of health must be enjoyed without discrimination on the grounds of race, age, ethnicity, or any other status. The second one is an economic argument. And we know that often one thinks that migrants are a burden on healthcare system, and they don't have a positive effect on host countries' economies. But this Lancet Commission that we had proved that the migrants are not, this is not the case. However, we do know that poverty is related to ill health, and therefore it's very important that we address some of the underlying causes like poverty in order to have better health. And this was also from the colleague in Turkey who calculated the cost of NCDs and the economic burden of NCDs in Turkey, which, as you can see here, is formidable. And then when you have a large population of the proportion of the refugees also with a burden of NCDs, it just makes the entire cost of NCDs really high, and therefore prevention is extremely important. The last argument, which I think is a very important argument, is the humanitarian argument, because we know that people will move either voluntarily or they will be forced to move. And we should not think that those who are forced to move do not have a significant burden of non-communicable diseases. They do have, in addition to maybe the communicable diseases that are short-term, but many of them have already chronic conditions, including mental and social health problems that I will not be going into in this particular talk. So I hope that I've sort of tried to get through the reasons why we should pay attention, that NCDs and migrants are an important area to address. And then what are the areas we really need to address? We have primary prevention. Primary prevention is extremely important. It measures the need to recognize that different refugee and migrant populations will be distinct in terms of social, cultural, and religious norms, and that will influence their modifiable NCD risk behaviors. So it's very important to start at primary prevention. However, we also know, because of migration and because of movement, there are gaps in the treatment continuity, especially of refugees and asylum seekers affected by non-communicable diseases. And this can have also impact on the outcomes when in terms of control of disease. And so the morbidity and mortality in these groups can be higher exactly because of this movement and gaps in treatment continuity. Mental health, as I said, should receive a priority attention. And the reason I'm mentioning mental health, even though it's not included in the wider definition of non-communicable disease, it's because often mental health occurs as a comorbid condition. If you have a chronic disease, then most chronic disease patients at some stage or the other also begin to really struggle with their mental health issues. And lastly, intersectoral action and health in all policies are fundamental for improving the health situation of refugees and migrants. So these are issues in connection with NCDs that we must pay attention to. So what are the key recommendations of our technical guidance? I don't have time to go through all of them, so I'm just summarizing them. First of all, it's strengthening integration of NCD prevention and management into primary healthcare, incorporating specific directives for refugees and migrants. It does not mean that we have to create parallel guidelines, but we have to adapt the guidelines that exist for the majority populations, because we know that some of the refugee and migrant groups have needs that are different. I cannot stress more the adopting multi-sectoral approaches to address social and environmental determinants of NCDs. A lot of NCD issues, as we have seen, are outside the health sector. And unless we have multi-sectoral approaches and collaboration, we're simply not going to succeed. So we need appropriate legal and fiscal instruments to develop health promotion environments. We also need to make sure that there's a commitment to universal health coverage that says we will leave nobody behind, not refugees and migrants, and ensure that they have early access to preventive and curative services. There's also important to invest in the adoption of chronic disease self-management programs, because we know that since it's chronic disease, the individual has to take responsibility for their condition as much as the healthcare services or providers, in fact, even more. And therefore, empowerment of the users, particularly those from refugee and migrant groups, are important. We must look at targeted cultural and linguistically relevant health education promotion campaigns, because sometimes the materials that are produced for the majority population may not apply to refugee and migrant groups. Ensuring a culturally competent workforce. It's very important that one of the biggest pillars of strengthening health systems, besides some of the structural issues, is the most important component of a health system is the health workers, it's the health force. They have to feel competent and they have to be enabled in order to treat the diversity that they see in the healthcare services. And finally, without having high quality migrant specific and sensitive data on NCDs, we will not be able to take action, because we will not know where the gaps are. And if we don't know where the gaps are, we can't really address them. We've had key recent policy developments.
Ben
that gives
araya giriyorum. Çok özür dileyerek sürenizi
Excuse me, I'm interrupting because you have used too much time than your allocated time. So may I give you a few more minutes?
my last slide. We have the UN Summit for Refugees and Migrants. We have the New York Declaration, and we can trace migrant health in the SDGs. So the moment for migration is now. Migration is our reality and our future. It needs to unite rather than divide us. Thank you very much for your attention.
Sayın Bernadette Hanım'a çok teşekkür
Thank you very
ediyoruz.
much, Ms. Bernadette.
Ve sunumunda bahsettiği çalışmaları
Thank you very much for this nice presentation. And I would like to state that this valuable information will be used, and I'm really pleased to listen to your presentation. Now, I would like to give floor to Professor Dr. Toker Ergüder from WHO Country Office, NCD Program Manager, because we know that during the pandemic, if we're talking about the refugees and migrants, we have more critical perspective. Today, Dr. Toker is going to have a presentation for us. The floor is yours, sir. Thank you very much, Melda. Thank you very much for your invitation, and I would like to greet you all with my respect because I can see there is a great number of participants. And once again, I would like to thank Professor Kumar because most of the slides will be very similar with my presentation. And once again, we have some other studies, and I'm really pleased to see my studies, which were also conducted in Jordan, and they are all accepted on international platforms. So for this reason, they're as references. I'm really pleased to see all those references. Secondly, I'm going to give a message maybe to Kumar. In the morning session, we have started a meeting with Dr. Mano in the morning in Ministry of Health. And as you can see, I'm going to show you this booklet. This is the Noncommunicable Disease Risk Factors Study. So we don't have the opportunity to repeat that. But in 2021, if we are going to have the opportunity, of course, if COVID led us, we are going to continue our study on risk factors because we included only Turkish citizens in the previous one. But for 2021, we will include everyone living in Turkey. So we are going to have a great sample size. And we conducted the previous one in 2015. This was related to the non-communicable diseases and the risk factors related to Turkish citizens. So we will have the opportunity to compare these two data, these two report results. So this will also be a good opportunity for us to evaluate and compare the data. So basically, I would like to share a few points, but Dr. Kumar shared most of them. When we talk about NCDs, we have 5 different risk factors, and we have 5 different disease groups. And until 2018, we had 4 risk factors and 4 diseases. But after 2018, with the decision of WHO, now we have the 5 risk factors. We increased the number of these risk factors, and we also included air pollution. We have cardiovascular diseases, cancers, diabetes, chronic respiratory diseases, and also the mental health diseases. So we have 5 right now. And when we talk about the agenda of NCDs, we mention these 5 risks and 5 diseases. In 2015, we announced the Sustainable Development Targets, and one of the SDG targets, 3.5, was on NCDs. So by 2030, reducing by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promoting mental health and well-being. So what do we mean by stating these mortalities, premature mortality? Because due to the increase of the cardiovascular diseases, we can see there is a great increase. But unfortunately, due to the increase in the population, especially the elderly population, there is an increase in the mortality, and of course this affects the non-communicable disease mortality, and it increased to 41 million globally. So this means nearly 55 million dies due to non-communicable diseases. So previously, this ratio was about 70, but now we have 75% generally. On the other hand, we're talking about 41 million individuals, and when we examine the age, we can see the age is not above 65. If we have the mortality before the age of 70 due to those diseases, we call it premature mortality. For this reason, we try to prevent all these mortalities related to non-communicable diseases. And of course, WHO provides annual reports, and we try to follow the figures related to NCDs. And we can see 89% of the deaths are from NCDs in Turkey. So 16% of is for the probability of premature mortality from NCDs before the age of 70. What does this mean? When we try to understand that picture, actually we are in better condition when we compare to the countries on the left-hand side, but in worse condition compared to the other side of the presentation. So we need to decrease these percentages, and we need to provide preventions. Of course, in 2013, the global NCD agenda was announced, and there are 10 basic objectives. First of all, identifying and implementing a specific set of NCDs, and also including essential NCD services in primary healthcare services, expanding the benefit packages, and also, for example, the seventh one is very important, treating people living with NCDs during humanitarian emergencies. Of course, we have our guests in Turkey, and we have our Syrian refugees, as Dr. Kanuni Keklik stated. We provide in Turkey, the Ministry of Health provides all the healthcare services for Syrian refugees. We provide treatment. And I also conducted a study in Jordan, and Syrian refugees were paying in order to buy a medicine or to receive from the services. So this is also a difficulty for the refugees. So we have set some targets for the future, for example, for hypertension and also for diabetes. We try to identify these targets for these NCDs, because if an individual has an NCD like hypertension, then they're going to have the access to free of charge healthcare services, and their diabetes, their hypertension will be under control. And this is one of the slides from Turkey. We made STEPS study together with Dr. Banu. So this is a brief summary. I'm sure this is very similar for the Syrian population, because we have more than 10 million hypertension. The adult population with hypertension is 16.9 million. And we can see the results, I mean the percentages on the slide, and also if the hypertension is lower, then we can see, for example, the average diagnosed under the treatment and the controlled. The controlled level is very low. We have a very comprehensive social universal coverage. So we are one of the best countries providing this universal coverage. And this is also acceptable for the Syrian refugees, especially for hypertension treatment. If you have the medical report, you are going to benefit from the services free of charge. And regarding NCD, I would like to share this with you. This is related to governance. We try to increase the governance. We try to discuss the financial part of this issue, and we try to include the NCDs in EML in terms of medicine and technology, and we try to increase the capacity of the healthcare workers and try to integrate all those services in healthcare services. As of 2020, you're going to see the roadmap of WHO package here. So this is the integration of primary healthcare services. So we have prepared thousands of brochures, guidelines, packages, programs, and all those documents have been translated into various languages. They are all uh, in different languages, including Arabic, not only for the treatment or the diagnosis, but also we have the risk factors, as I have stated in my previous slide. So we prepared technical packages. For example, they are related to tobacco use, physical inactivity, consumption of food, high in salt, consumption of food with trans fatty acids and high blood pressure. They are all different packages. And we work together with Dr. Banu, especially for NCDs, and we adapted and we try to adapt them in the primary healthcare services. And of course, we have this package. This is also prepared by Gaziantep office for the Syrian refugees, and this is already applicable in northern part of the country. This is for the adaptation of NCDs in primary healthcare services. So the management of all those diseases in primary healthcare. There are different steps, either being a Syrian citizen or a Turkish citizen. When you apply to primary healthcare service, first you need to have the registration, then there is the pre-assessment, like a calculation, measuring the height, weight, blood pressure, etc. Then completing the initial section, then moving to treatment room and receiving the treatment. Generally, this is something very traditional. Globally, if you're talking about NCDs, we pay less value to NCD because mostly we focus on the other diseases, and also the financial resources are not sufficient. But when in 2019, health systems were unable to fully respond to the majority of countries to the healthcare needs of people living with and affected by NCDs. But then we can see some figures related to the NCDs, and we are aware of the importance. And this year we have COVID-19, this pandemic. Of course, as I stated, the budget allocated and also the interest on NCD was not very high. Since the COVID-19 outbreak, people living with NCDs are more vulnerable to become severely ill. And now we have the social distancing, people stay at home and people are afraid of being on the streets. For this reason, there could be an increase in comorbidity and mortality, but we have the first issue as the COVID-19. And there was an evaluation, this was a rapid assessment, and we have received the feedbacks of the ministries, and also we included the General Directorate of Public Department of Chronic Diseases and Elderly Health. We have collected all the data, and I would like to share some of those slides from that study. In this slide, you can see 122 countries reporting NCD services are disrupted. For example, rehabilitation services are disrupted, hypertension management, diabetes, and diabetic complication management, asthma services, palliative care. So they're all under the scope which are disrupted. So these services are very important, especially with COVID-19 outbreak. We have the elderly care centers and disabled care centers. We protected them in those centers in rehabilitation services, and we try to decrease the number of mortalities there. And especially with the COVID-19, once again, we can see complete or partial disrupted services. And then Of course, we ask different questions to different countries. And as you can see, this is for the main causes of NCD service disruption. And they have stated 75 of the countries reporting the disruptions, especially for the decrease in inpatient volume due to cancellation of elective care. And also, for example, in outpatient clinics, family physician centers, they stopped providing services due to COVID-19. So for the treatment of non-communicable diseases, we realized that there was unavailability or stock out of essential medicines, medical diagnostic and health products. And of course, this is an emergency. For this reason, some of the healthcare workers moved to some other emergency departments. Moreover, we asked another question to the countries. And 66% of countries have included the continuity of NCD services in national COVID-19 plans. This is something promising because you can see, for example, low income, lower middle income. COVID-19 plans include all these issues, and NCD services will continue in 66%. Okay, you are going to continue, but what about the budget side? Unfortunately, 17 of countries allocated additional funding from the government budget to include the provision of NCD service into the national COVID-19 plan. I hope there will be an increase in this plan because unfortunately individuals are afraid of receiving from these services. They try to postpone some of the cases for diabetes, for cancer treatment. One of the most important one is cancer. And also for the COVID-19, they don't want to visit the hospitals. We don't know what will be the burden size because these days we postpone most of the treatments. So what will be the burden on the governments? And how are we going to find solutions after facing this burden? So they are all going to increase or decrease the figures. We don't know yet, but the government should consider all these issues. And during the COVID-19, in order to provide better services to the patients, we try to use more innovative approach. For example, WHO Europe, they try to establish a commission in December, especially for NCD, for example, telemedicine. And also there will be tasks shifting, role delegation, or there will be dispensing approach. So innovative approach and technologies will be used, and these will be prepared in terms of guidelines for the countries. And we are going to continue working together with the Ministry of Health, especially using telemedicine deployment, and we are going to use different technologies, and we will try to integrate them into the primary healthcare services in order to manage the NCDs remotely. And of course, today the world is at a very critical juncture, and all these other plans are included under the scope of COVID-19. These services have been provided, and all the countries are working very hard to find solutions. We hope in the future all the countries will pay more attention to NCDs, especially for national rapid assessment plans. They will include all these NCDs, especially for the chronic diseases and the primary healthcare services, and they will establish the bridges between national humanitarian emergency plans and NCD responses. Then there will be more resources allocated, and we are going to minimize the burden of NCDs. Moreover, we have the digital healthcare solution. So we are planning also to develop systematic approaches in the world. Once again, thank you very much for listening to my presentation, and I would like to share my colleagues who have contributed to my presentation. As WHO, we have been working together at 3 different levels. We have WHO headquarters, WHO Europe, and also WHO Turkey's office. And I would like to share my colleagues on behalf of my Ankara office and also for the Europe and country office. Once again, thank you very much. Thank you, Melda. I hope I use my time very appropriately. Thank you very much for your presentation. As you have stated in your presentation, sometimes, of course, we need to focus on the emergency, but we need to consider the NCDs as well. Now we are going to proceed with the panel session, and we are going to have the moderator for the panel session. I would like to give floor to Dr. Serap Şener. She is going to be the moderator for the panel. I give floor to you, Madam. Thank you very much.
Hepinizi sevgi ve saygıyla.
Thank you very much. First of all, I would like to greet you all with my sincere respect and of course, I had the opportunity to work together with all those familiar faces, all those colleagues, and I can see that there are three very valuable professionals in this panel. I'm really pleased to be together with you. Okay, in this symposium, there are two main significant reasons. Of course, as of the beginning of this symposium, all the speakers highlighted these issues. Of course, they are the fundamental ones. One of them is, as we all know, the reality of today. Unfortunately, due to some different reasons, we have a great population who are leaving their own countries, and secondly, epidemiological changes seen in NCDs of refugees. Today, we can see there is an increase, and there is a rapid increase in terms of the prevalence of NCDs in refugees. So, not only for the refugees, migrants, asylum seekers, they all can have the application to the primary healthcare services. And also this increased the burden on the primary healthcare. And then there could be some unexpected results if we cannot follow up all these increase in an appropriate manner. As you all know, due to the crisis started in 2011 in Syria, this was one of the most comprehensive migration. And these migration routes were moving towards different places. Of course, there was an acceleration. We have prepared the guidelines, preventive coverage, effective response documents, which are also evidence-based. And we have accelerated all these works. I wish we had not seen such sad situation for them, but these people who had to leave their countries, this is first of all providing these services, these healthcare services, and accessing these healthcare services and humanitarian right. For this reason, especially for the cultural and language barriers, we need to focus the primary health care services. And we need to strengthen the services at this level for the refugees. So we continue and we understand all these activities are very essential. We host 4 million refugees and migrants in Turkey. And when we consider the current health system, then we try to provide the services for the Syrians under temporary protection, and we strengthen the healthcare services in our country. Now, first of all, I will give floor to Dr. Bahadır Sucaklı, and he is going to brief us about the strengthening works. Later on, we are going to have the next speaker, and we know her that she is always supporting us, and we know she has been working very devotedly together with her team, Dr. Banu Ekinci. will be the second speaker. And then we have the third speaker, a very valuable presenter, Dr. Seçil Özkan from Gazi University. She is also going to talk about the issue, and she's going to shed light on some specific issues. Now I would like to give floor to Mr. Bahadır, and I would like to spare some time for the questions. So please use your time efficiently. I'll give
Çok
15
teşekkür
minutes for
ediyorum
your presentation.
Serap Hanım.
Thank you very much, Mr. Serap.
Aslında bir giriş
Actually,
yapmış oldunuz.
you made a very
Dolayısıyla
good
bu girişin
introduction.
üstüne ben de
So,
Upon this introduction
sunumumda
and my
biraz daha detaylara girmek
presentation, I
istiyorum.
would like to get
Dünya
into
Sağlık
a bit
Örgütü
more with detail.
göçmen ve mülteci sağlığı konusunda neler
WHO,
yaptı?
what has
Sizin de söylediğiniz
WHO
gibi
done about
ve
the
Bernadette Kumar'ın
refugee
da
and
konuşmasında
migrant health?
farklı bir
As
kavramla
Ms.
yani yavaş
Bernadette
çekimde
Kumar
izlediğimiz bir
used the
sağlık acil
concept
durumu
of
kavramıyla ifade
slow
ettiği
motion
son 10
in
yıllık
a,
süreçte
a
ne kadar
health
çok
emergency in a
aslında
slow
çalışmalar
motion concept. Actually, this is
yapıldığını
describing
ben
this
de
situation
bu
very
sunumu
well.
hazırlarken tekrar
And during
gözden
my
geçirmiş oldum ve
presentation, I have made a
gerçekten
review of all the
sunuma
activities
sığmayacak
that
kadar
we
aslında
have
birçok
carried out. And
işbirliği
indeed,
yürütmüşüz Sağlık
we
Bakanlığı'yla
have
ve onların
conducted
çalışmalarına
a
destek
high
olmuşuz.
level of
Tabii bunların
collaboration. We
hepsi
have
aslında
supported the work of
en yüksek
the
sağlık düzeyine
Ministry of Health.
tüm
And
insanları
at the highest
ayrıştırmaksızın
level of
kavuşturmak
health,
temelindeki Dünya Sağlık
we
Örgütü
would like to
Anayasası'nın
unite all the
bize
people without any
vurguladığı
discrimination.
hususları
So this
gerçekleştirmek
is the
için
constitution of the
yaptığımız
World Health
şeyler.
Organization, and
Çok
all
temelde
of our
Dünya Sağlık Örgütü
activities
aslında norm
are
ve
to this
standartların
end.
geliştirilmesinde, araştırma
In the
gündemi
development
şekillendirilmesinde,
of
kanıta
the
dayalı sağlık politika seçenekleri
norms and
geliştirilmesinde,
standards
sağlık
and the
trendlerinin
information of
takibi
the
ve buna
health
bağlı
research
kapasite
and
inşasında
in the
ve
development of the
yine çok
evidence-based
ihtiyaç
health
duyulursa
policy
eğer kritik
options
sağlık konularında
and in providing
doğrudan
support
liderlik yapmak
to
yoluyla
the
dünya
capacity
sağlığına
building
katkıda bulunmaya
and
çalışıyor.
technical support in the health
Mülteci ve göçmen
area. WHO
sağlığında bir
has
takım
been working.
stratejik
There are
belgeler son
certain
zamanda
strategic
ortaya kondu. Bir
documents
strateji
in
planımız
the
Avrupa bölgesi
migrant
için
and
artık
refugee
var.
health. We have a
Ve bu
strategic
strateji
plan for the
planında da
European region, and in
konuyla
this
bağlantısı
strategic
olması
plan,
bakımından temel
in this
alanlardan bir tanesi
strategy
de
plan,
bulaşıcı
one
olmayan
of the
hastalıklar.
main fields is
Dolayısıyla bulaşıcı olmayan
non-communicable
hastalıklar
diseases.
mülteci ve göçmen sağlığının
Therefore,
önemli bir
the
konusu olarak
non-communicable
belirli
diseases has
takip
been
göstergelerine
set
bağlanmış
as
şekilde
an
artık
important
çalışma
subject
programımızda
item
bulunmakta.
of the migrant and refugee
Buna
health,
ek olarak
it
Dünya
has been
Sağlık
placed
Örgütü
into
acil
our
durum
program.
programından
In
bahsetmek isterim.
addition
Tabii
to that, I would like to talk
son
about WHO
birkaç 10
emergency
yılda
program.
acil durumların
In
nitelinin
the
değişmesi, Dünya
recent
Sağlık Örgütü'nün
decades, the
bu acil
quality
durumlara
of
müdahale hızı ve
emergencies has
etkinliğinin
been
geliştirilmesi için
modified, and
farklı bir
for
yaklaşım
developing the
ihtiyaç duyulduğu anlaşıldı ve
rapidness
Sağlık
and
Acil Durumları
effectivity
Programı
of WHO,
oluşturuldu.
there
Bu
was a
acil
need
durum
for a new
programının
approach,
temel
and for this
noktası
reason,
iş
this
gücünün,
emergency
bütçenin,
program has
sorumluluk
been formed.
zincirlerinin ve
The labor
akışın
force,
aslında
budget,
bir araya getirilmesi ve
responsibility
bu tek idari
chain,
sistemde
and the
etkinliğin
flow
artırılması. Bir
was
önemli
handled,
noktada
and
bu
the
yapıyı
single
şekillendiren
administrative
acil
system
durum
is being
yanıt
used in
çerçevesi
order
belgesinde
to
Dünya Sağlık Örgütü'nün
identify this
temel prensiplerinden
framework
birinin
document. One of the
acil
fundamental
durumlar ve
principles of
kalkınma ile
WHO
ilgili
is related
hususları
with
bir araya getirmesi.
emergencies and
Yani acil
development, and
durumun
it has
aynı
been
zamanda
gathering
kalkınma için hem
together
bir araç hem de
the
bir basamak
emergencies
olduğunu
and
vurgulanması.
development, and it
Bu kronik
emphasizes that
hastalıkların yönetimi
emergencies
ve
is
uzun
a tool
vadeli
and also a
planlaması
step
açısından
for
da bizim
development.
için önemli
And this
bir
is an important document for
zemin
us.
teşkil
It's an
ediyor.
important
Peki Türkiye'de
floor
ve bu
for
program
us for
çerçevesinde ne
planning the
yapıyoruz?
long-term
Sağlık kümesi
activities.
dediğimiz
What do we do in Turkey?
cluster diye adlandırdığımız sağlık paydaşlarına liderlik etmeye
The
çalışıyoruz.
health cluster,
Paydaşları
which is
koordine etme,
composed of
bilgi
our
yönetimi ve planlama,
stakeholders, the
sağlık
coordination of
operasyonlarına
stakeholders,
destek verme ve
the information
lojistik ve
management and
operasyonel
planning,
destek sağlama
supporting the
başlıkları
health
altında
operations and
çalışmalarını
technical
yürütüyoruz.
activities, and operational technical
Yapıya
support
baktığımız
is
zaman
another
Ankara'da
activity
bizim
field
ülke
of us.
ofisimiz var. Ülke
In
ofisimiz
Ankara,
acil
we
durum
have country office. Our country office
yürütüyor.
is
Türkiye
carrying out
için yürütüyor.
emergency operations
Ve
for Turkey.
bunun içinde Birleşmiş Milletler
And for
kuruluşları
that,
ve diğer
United
paydaşların
Nations
hep beraberce
organizations and other
hazırladıkları Suriye
stakeholders
krizine yanıt için
have
TRP olarak adlandırılan
prepared
plan
a
çerçevesinde
plan
çalışmalarını
which is called
yürütüyor.
3RP
Bizim Gaziantep'te de bir
for
ofisimiz var. Sınır
intervention
ötesi
to the
çalışmaları
Syrian crisis.
yürütüyor. Kuzey
We have
Suriye'de
another office
desteğe
in
ihtiyaç olan
Gaziantep,
nüfusa
which is working
destek olmaya, buradaki
transborder
paydaşları
at a
desteklemeye gayret
transborder
ediyor.
level, and
Şu
it
an
is
için bu
trying
bizim
to
sorumluluğumuzun
support
dışında
the
olan bir konu.
activities in Syria.
Genel olarak
However, this is
aktivitelere
not in the scope
baktığımızda
of my presentation right
adaptasyon
now.
eğitimleri,
What are the
sürekli
activities? The
eğitimler ve
adaptation
operasyonel
trainings,
destek yoluyla aslında
continuing
biz
trainings,
eğitimleri bir yandan
operational
ele aldık.
support are
Merkezler
under
var.
the
Göçmen
title
Sağlığı
of
Merkezleri,
trainings.
Kanuni Bey
We have
bundan
centers
bahsetmişti.
of migrant
Toplum sağlığı
health.
destek
Mr.
personelinin
Dr.
bu
Kanuni talked
merkezlerde
about that.
yer
And
alması,
community
istihdamı
health
yoluyla
personnel is
bu
being
eğitimleri
employed
aslında
in these
istihdama
centers.
dönüştürmek
So
yolunda
in this
destekler
way, we are
sağladık.
supporting,
Bir de
we have
tabii
supported them
araştırma ve
in order to turn the
değerlendirmeler
trainings
yoluyla
into the
ve
employment.
bir
And we
şekilde
have conducted
bunları
research and assessment,
görünür kılma
and
ve
we
bütün
have been
paydaşları
also working on communication and
bütün bunlardan
visibility,
farkında
so
hale
that
getirmek
all
için
the
iletişim
stakeholders are
çalışmalarıyla
aware
beraber
of all these
geliştirmeye
activities.
çalıştığımız bir aktivite
So we
zincirimiz var.
have been trying
Peki
to develop
her
this
birinden
chain
ayrı ayrı
of
bahsedeceğim ama
activity. I'm going to
bir
talk
araştırma
each of
grubumuz
them
var.
one
Çeşitli
by one.
araştırmaları
We have a
Sağlık Bakanlığı ile
research
beraber
group
yürütüyoruz.
conducting various studies
Çeşitli
together
eğitim
with
faaliyetleri
MOH.
yürütüyoruz. Bu
We are
eğitimlerin
carrying out various
en
training
önemli kısmı belki de
activities. And the most
Suriyeli
important
sağlık
part of this
çalışanlarının Türk
training
sağlık
is the
sistemine adaptasyonu için
adaptation of Syrian
gerçekleştirilen
health
eğitimler.
workers
Bunun
into the
dışında
Turkish health
sürekli
system.
eğitimlerimiz de
Apart
söz
from
konusu.
that, we have
Bunlardan da bahsedeceğim.
on continuing trainings on
Adaptasyon eğitimleri önemli demiştik. Doktorlar, hemşireler,
lasting
laboratuvar
trainings. The
teknisyenleri,
adaptation
röntgen
trainings are
teknisyenleri ve
applied
hasta
to
yönlendirme
doctors,
personeli.
nurses, lab
Bu
technicians, X-ray
meslek
technicians, and
gruplarına Türk Sağlık
patient
Sistemi'nde Sağlık
referral
Bakanlığı'nın
personnel.
oluşturduğu
These people
göçmen
have
sağlığı
been
merkezlerinde
trained
çalışmak
in
üzere bir
order to
yeterlilik kazandırmak
work
adına
in the
hem
migrant
teorik
health
eğitimler hem de
centers of
pratik
Turkish Ministry of
eğitimler
Health.
olmak
We have
üzere bir
delivered
eğitim programı
theoretical and
hazırlandı ve
practical
hali
trainings
hazırda bu
for those
merkezlerde çalışan,
personnel. And
Suriye'de
the
eğitimini
people
almış, daha sonra
who
Türkiye'ye
received their
gelmiş
education in
olan
Syria and
tüm
who came to
meslek
Turkey
mensupları
later,
bu
all the
eğitimlerini alarak bu
professionals
merkezlerde çalışıyorlar.
first get this adaptation
Sürekli
training
eğitim
before working
tabii
in
her
those
zaman
centers.
gündemimizde oldu. Zaman içerisinde gerek
Continuous
operasyonel
education
destekler sağlama
training is
gerekse
always on our agenda.
bakanlığın
We have
planlı
operational
şekilde
support,
tüm sağlık
and
çalışanlarına
we are
vermek istediği sürekli
also
eğitim konularında
supporting
çeşitli
Ministry of
eğitimler
Health
düzenledik. Ruh
for the
sağlığı
ongoing
eğitimleri,
trainings
bilgi
to the
sistemlerine dair
existing
eğitimler,
personnel.
bulaşıcı olmayan
We have
hastalıklarla
delivered
ilgili
trainings
eğitimler,
about
iş
mental
sağlığı ve
health
güvenliği
and
gibi eğitimler. Bunların
trainings about
en
non-communicable
önemlileri arasında.
diseases,
Tabii
the
son dönemde bir de
labor,
Türkçe dil eğitimi konusunda
vocational health
bir
and
destek
safety
sağlamaya başladık.
trainings, and
Bunu da
most
çok
recently we have
önemsiyoruz çünkü
provided support
Türkçe
about
dil
Turkish language training. This is
becerilerinin
very important for us because
yeterli
Turkish language
olmadığı
skills
konusunda Suriyeli sağlık çalışanlarından sürekli geri bildirimler
we
alıyorduk.
are
Aynı
getting
zamanda onların
feedback from Syrian health workers
tam
that their Turkish
akreditasyonu
language
için
skill is
aslında
not
mesleki
sufficient,
anlamda bu tip
and for
becerilere de
their full
ihtiyaçları vardı.
accreditation
Dolayısıyla
in
Türkçe dil eğitimini
professionally
de bu sürece
they
dahil
needed
etmiş olduk.
language skills, so we
Önemli
have included Turkish language
değişimlerden bir
education.
tanesi aslında
One of the
COVID
important
öncesi ve sonrasına
changes
dair söylenebilir.
in the
COVID
pre-COVID,
öncesinde
between pre-COVID and
yerinde
post-COVID era is this. Before the
sınıflarda ya
COVID,
da
we gave
eğitim
in place
ortamlarında
trainings
eğitimleri,
in
yüz yüze
classrooms or
eğitimleri
in teaching
tabii ki daha çok
environments. We have
uygularken
delivered
COVID'den sonra
face-to-face trainings.
mecburi
However, after
sebeplerle
COVID, because of the
uzaktan eğitim alanında ciddi bir yatırım ve
existing
geliştirme
situation, we have
çabasına
made an
giriştik
important
ve
investment and development about remote
uzaktan eğitim
training.
ve hizmet yerlerinde de pratikler
And because of remote training,
kombinasyonlarıyla bu eğitimlerimize
we
halihazırda
have
devam
combined
ediyoruz.
remote
Bunun
training and
bize
the
hem bir
practical
takım
training in the
dezavantajları oldu.
service
Tabii ki
provision
eğitim
centers. There were
sağladığımız
certain
insanlarla yüz yüze
disadvantages
bir etkileşim
because
içine girmek
we
isterdik ama bu
wanted to be
şu
in
anda
a
o kadar da mümkün
face-to-face
olmuyor. Bunun
interaction with
yerine
the
uzaktan eğitim
trainees.
veriyoruz ama bu
However,
sefer
this
daha
is
çok insana
impossible. We
daha
can
farklı
deliver
sürelerde
only
ulaşma
remote
imkanımız
training.
ortaya çıkıyor.
However, this
Bu da
time
bu sürecin
we can
avantajlarından bir
access,
tanesi.
we can reach out to
Çok
many
kalabalık bir araştırma
more
grubumuz var.
people
Yani
compared to the
saha araştırmaları
face-to-face
ve çeşitli
trainings. We have a
alanlarda
very
araştırmaları,
populous
Sağlık
research
Bakanlığı'nın
group. We
ihtiyaçları ve
can
sahadaki
provide
ihtiyaçlar
field
çerçevesinde
research, field
planladık ve
surveys. We have
uyguladık.
planned and
Kimileri de
implemented
uygulamaya devam
them
ediliyor.
according to the needs of the
Böylece
Ministry
Sağlık
of Health.
Bakanlığı'nın program yönetimi konusunda
In this
politikalarını
way, we can
desteklemek
support the
ve
policies
sağlık
of the
durumunu ortaya
MOH
çıkartmak
about program management,
bakımından
and we
destek
can
olmuş
reveal
oluyoruz.
the state of
Bunların
health
içerisinde
in
daha önce
Turkey. Among them,
konuşmalarda da
there is
bahsedildiği
one
gibi birçok
study which was
bulaşıcı olmayan
mentioned in one
hastalıklarla
of the
ilgili
earlier
araştırmalar da söz konusu.
speeches. There are many
Operasyonel
studies
desteğimiz
about, there are
temelde
some studies about non-communicable
eğitimlerin
diseases.
aslında
Regarding
eğitimlere bir
our
zemin
operational
kazandırması
support, in
şeklinde
order to,
başlamıştı.
we started
Türkiye'de
them for
kurulmuş olan Sağlık
providing
Bakanlığı tarafından kurulan
grounds for the training.
7
In Turkey, there
güçlendirilmiş
are
göçmen sağlığı
7
merkezinin aynı
enhanced
zamanda eğitim merkezi olarak Dünya
migrant
Sağlık Örgütü
health
tarafından
centers,
desteklenmesi
and they
ve
are
buralarda
supported as training
Suriyeli sağlık
centers by
çalışanlarının
WHO,
pratik eğitimlerinin
and Syrian
desteklenmesi
health
yoluyla ve
professionals
güçlendirilmiş bir
were
hizmet verilmesi
receiving
yoluyla
practical
bu
training
teknik
here.
destek
And this is
devam
a
etti ve halen
technical
devam ediyor.
support which is still
Bir
going on.
diğer destek alanımız
Another
yaşlı ve engellilerin evde
support
sağlık bakımı
area is
desteklenmesi. Bu
home
da
care for the
çok önem
elderly and
verdiğimiz
disabled
ve
persons. We
bu
attach a great
toplantıda da
deal
bize
of
destek olan
importance to that.
Alman Kalkınma Bankası'na
The
da
German Development Bank has been
finansal olarak
supporting this
desteklediği
financially,
evde bakım elemanlarının istihdamı
and
ve
we
bunların
have employed home
evde sağlık
care
bakım
staff,
sürecinde kendi
in the home
vatandaşlarına hizmet
healthcare
verecek şekilde organizasyonu.
process, they have
Tabii
been
ki
organized
destekleyici bir
to
takım personelin
provide
de bunun yanında
services to
istihdamı söz
their
konusu. Psikologlar, sosyal
co-citizens.
çalışmacılar,
Also, we have
hasta yönlendirme
employed
personelleri,
psychologists, social
bütün
workers,
bu operasyonu
patient
mobilize edilmesi
referral
için
personnel,
gerekli araçlar,
and we
şoförler,
have
bunların
provided the
giderleri,
drivers and the
evde bakımla ilgili
vehicles,
süreçlerde
and their
gereken
expenditures
tüketim
were also
malzemelerinin
covered,
sağlanması
and also the
gibi bir
consumables
takım
required
bileşenlerle
for home
diğer
care
destekleyici
were
operasyonlarda
provided, and we have
sağlanıyor bu kapsamda.
also making
Temel
some
amacımız hani
supporting
incinebilir sağlık
operations in this
hizmetlerinden
scope.
daha az
Our
faydalanma
main
durumunda olan
focus
dezavantajlı
is to
grupların
provide
desteklenmesi.
support to
Bu
the
çerçevede bir önemli
vulnerable
noktada
and
bütün bu
disadvantaged
çalışmalar
groups.
çerçevesinde Aile Bakanlığımızla
In
da
the frame of
ve
all
onun
these
ilgili
works, we
birimleriyle
have
de
been
yakın
working
bir işbirliği
together
içerisinde
with the Ministry
çalışmamız
of
ve
Health
böylece bakanlıklar
and their
arası
relevant
ortak
units.
çalışma zemininde
In this
güçlendirmeye
way,
gayret
we have
ediyoruz.
been strengthening the
Başka
common
bir takım
ground
operasyonları da
between
hani
the ministries.
başta söyledim ya
There are some other
aslında baştan beri
operations.
düşündüğünüz zaman ciddi
Since
miktarda
starting
farklı
from the
alanlarda
beginning,
işbirlikleri
we
yaptığımızı
have made very
tekrar hatırlama
significant
imkanı buldum ben de
collaborations
Sağlık
in
Bakanlığı ile
the
diğer
different
birimlerle.
fields with
Dijital sağlık
MOH and
uygulamalarının
other units.
desteklenmesi konusunda
We
bir
supported
işbirliğimiz
digital
oldu.
health
İzmir'de bir pilot çalışma yürüttük.
implementations.
Anne ve çocuk sağlığı hizmetlerinin
We
güçlendirilmesiyle
have
ilgili
also
Şanlıurfa'da bir
worked in
çalışmayı beraberce
Şanlıurfa
yaptık. Çocuk ve
about
bebek izlem
enhancement of
rehberi
maternal and
uygulamasının
child
hazırlanmasında
health
bakanlığımızın ilgili
services.
birimiyle beraber
And we
çalıştık.
have worked
Açlık
together
ve
with the
obstetrik
ministry
bakım
unit
eğitimlerinin
in
desteklenmesi
the
konusunda
child and
birlikte çalıştık.
infant
İstanbul'da bir otizm tanı
observation
ve tanı tedavi ve takip merkezinin
guidelines.
kurulması ile ilgili olarak
And we have supported
İstanbul
the
Sağlık
emergency
Yönetimi ve Sağlık Bakanlığımızla
obstetrical
beraber
care
bir çalışma
trainings. We
gerçekleştirdik.
have established, we have
Birçok
supported
ilde
establishment of an autism
aslında Sağlık Bakanlığı tabii ki
diagnosis,
temel
treatment
altyapı
and
kurucu ama bu
monitoring
altyapının
center.
desteklenmesi için
So
ciddi
in many
yatırımlar
places,
yapma
the
imkanları
main
bulabildik bu süreçte.
infrastructure is
Gaziantep'te,
made
Şanlıurfa'da,
by
Konya ilinde
MOH, but we have made
sağlık
important
altyapısının, göçmen
investments
sağlığı
about
altyapısının
migrant
desteklenmesi
health
konusunda
infrastructure
Sağlık Bakanlığı
in
ile beraber
Şanlıurfa,
çeşitli
Gaziantep,
yatırımlarımız
and
oldu.
other
Gebe
cities.
sınıflarının
We have
oluşturulmasında
formed
destekler
pregnant
sağladık. Bu sınıflar
classrooms. We
yoluyla
have supported
gebelere
ministry in
gebelik dönemi sürecinde
the
eğitim
classrooms
verilmesine katkıda
for
bulunuyoruz.
pregnant, so
Aktif
that
yaşam
they
merkezlerindeki
pregnant
katkı
people
aslında kronik
are
hastalıklar bakımından
receiving
çok değerli.
trainings.
Çünkü
Active Life Center is very
göçmen sağlığı
valuable in terms
merkezlerinde,
of
güçlendirilmiş
chronic
göçmen sağlığı
diseases.
merkezinde aktif
So
yaşam
in enhanced
merkezleri
migrant
kavramı
health
içerisinde de
centers,
değerlendirilebilecek
they
diyetisyen,
are
fizyoterapist gibi
dietitians,
personelin istihdamı,
physiotherapists
bu altyapının
were
oluşturulması konusunda bir
employed,
işbirliğine
and this
gittik
is
ve çok verimli olduğunu
requiring a
memnuniyetle
collaboration in
gördük.
the formation of this infrastructure, and
COVID
we
ile
were
ilgili
very happy
çalışmaları
to see that it was
açıkçası
very
hani
much
baştan aşağı saymak istemiyorum.
efficient.
Ciddi miktarda
I do not.
hemen bu son
Bahadır Bey,
slaytım
would you
Serap
please
Hanım.
wrap up? Yes,
COVID
this
ile
is
ilgili
my last
çalışmalar
slide.
oldukça uzun bir liste
Concerning
tutuyor.
the COVID,
Dolayısıyla
we
bunu
have a
tek tek
long
saymaya
list
gerek yok
of
ama
activities. There is no need
göçmen
for
sağlığı ile ilgili
reading that
çalışmaların
list.
COVID sürecine
But
adaptasyonu
the
konusunda da aslında
adaptation
beraberce
we have
çalışıyoruz.
we have been
Bütün
working
bunların yanında
together
şunu da
in the
vurgulamak
adaptation of migrant
zorundayız.
health
Tabii
works
Dünya
to the
Sağlık
COVID
Örgütü'nde bir acil
process.
durum programı var.
In
Bir
the
de
WHO, there's an
göçmen
emergency
sağlığı
program,
programı ayrıca
and
var.
we also have
Göçmen
a
sağlığı
separate
programını da
migrant health program. And
çeşitli
this
çalışmalar
program
yürütülüyor ve bu
is
kapsamda da Sağlık
also
Bakanlığı'yla yakın
covering a large
şekilde
scope
beraber
of a
çalışıyoruz.
wide scope of
Tabii gelecek dönemde de bu
activities
çalışmaların
in which we are working
artarak
together with
sürmesi
MOH.
istiyoruz.
We
Özellikle de
wish
politika
these
geliştirme süreçlerinin
cooperations
desteklenmesi,
continue in
yeni
the
veriler,
future,
bilgiler
in
oluşturulması
particular
konusunda Sağlık
supporting the
Bakanlığı'yla
policymaking process
işbirliklerimiz
and
devam
in
edecek.
creating new
Ben
data
çok
and
teşekkür ediyorum
information. We
ama
will
esas
continue to
teşekkürü
work
de
together with
bir
the
kısmı da bu
MOH. So
sempozyumda
I'm very
dinleyicilerimiz olan,
thankful, and I would like
bu
to
hizmetlerin
thank in
Suriyelilere, ülkemizdeki
particular
Suriyelilere
to
ulaşmasını
the
sağlayan Suriyeli ve Türk
Syrian
sağlık
and Turkish
çalışanlarımıza
health professionals
gitmesi
who are
gerekir.
making sure
Özellikle
that
onlara
these
çok teşekkür ediyorum.
services are reaching to the
Söz sizde Sayın Başkan.
migrant population. The floor is yours, Ms. Chairperson.
Çok teşekkürler.
Thank you very much, Bahadur.
Hemen sözü Banu Hanım'a vereceğim
I will give the floor to Ms. Banu Ikinci, but in the primary health care, non-communicable diseases, prevention of non-communicable diseases,
birinci basamağın önemi herkes tarafından vurgulandı. İkinci önemli bir şey
everybody has emphasized the importance of primary health care in the prevention of non-communicable diseases. And secondly, when we are talking about migrants, the primary health care services should be provided without language barriers. And for this reason, WHO has trained the Syrian doctors and health professionals for provision of this service. So this was a very important service. Now we are going to listen to Ms. Dr. Banu Ekinci, and she will be talking about the relationship of these diseases.
Bu güzel toplantı için tüm katılımcılara saygıyla selamlıyorum.
Thank you very much for this nice meeting, and I'm extending my respect to all participants. So far, I would like to talk about our policies about non-communicable diseases and what we have done in this process. Now I'll be sharing my presentation with you. Now, while talking about my presentation, the international framework has been mentioned, so I'm going to skip the parts which have been discussed by previous speakers. And while talking about our works, I'm going to talk not only about our activities for Turkish citizens, and I will also explain how they will be reflected to the Syrian migrants. In our country, non-communicable diseases are among the most important problems, and as the WHO and United Nations are recommending policies to the countries, and we are trying to find out ways for implementing those policies. We are following up the international policies, and we are trying to adapt them to our country. In the government development plan and in the strategic plan of MOH, we have certain policies concerning non-communicable diseases, and also at the same time, we have certain goals until 2030 concerning the non-communicable diseases. I'm going to talk very shortly. We have certain programs about risk factors like tobacco control, etc. And we also have programs on specific non-communicable diseases like chronic respiratory diseases. Programs are in action since 2008. So, but about those programs, first of all, we are trying to protect the community from the risks. In this scope, we have many activities for raising awareness about health risks. In all our provinces, we are trying to expand those activities, and we have also translated the documents in the language of Syrian migrants. So raising awareness is not enough. We are also working to ensure that there is a preventive health services perspective. We have prepared guidelines for Turkish doctors and Syrian doctors, and we have made certain trainings for them. We are using social media actively for raising awareness. In provinces, we have planted trees and we use the local media and we have been making press releases, and every year we have been updating those materials, and we are distributing them to the relevant persons. For health professionals, we have been organizing certain training activities, and as mentioned by Mr. Bahadur earlier, we used to have face-to-face trainings, but now we are doing remote trainings. We are planning to have a new model about management of non-communicable diseases. Actually, we have been working on this plan since 2015. The family physicians and healthy life centers should work together. We believe that only family doctors cannot do this, cannot manage this. So the family physicians should monitor the hypertensive or diabetic patients that are in their scope. And in addition to that, dietitian, social worker, and psychologist should be in the team of the family doctor in the management of these diseases. We wish like it would be so good if we had the dietitians or psychologists in every family health center, but because of high number of population in Turkey, we have set up certain healthy life centers. There are some psychologists and social workers. At the moment, we have about 200 health life centers. We would like to establish 1,000 centers. If family physician thinks that the hypertensive or diabetic patients needs advice on the diet, they can refer those patients to the dietitian or psychologist or whatsoever in the healthy life center. In the individuals, there would be individual interventions as well as group interventions in the healthy life centers so that we can control the diseases very well. There are 17 million hypertensive patients, and only 23% of them are under control. And this is a problem which we should improve. In our uh, country, the coverage of universal health care is more than 80%. So there is not any financial problem in accessing the medications. However, in receiving the expected benefit from the treatment, we have certain problems. And this is because the patients are not monitored properly. In our country, we do not have referral system, so the patients can apply to the health services whenever they want. However, we think that the patients should be followed up regularly. For structuring those activities, we made a health system assessment together with WHO in 2017. We have identified the gaps and we have implemented certain activities for filling in those gaps. So these activities about the screening of non-communicable diseases in our community, we have set up certain parameters and we have prepared monitoring guidelines in the primary health care. In our country, there are several guidelines about the diseases prepared by the professional organizations, professional medical organizations. However, we have prepared a guideline for the management in the primary healthcare system. In the family doctors in Turkey received trainings about cardiovascular diseases risk assessment in 2017. And we have planned that Syrian doctors should receive similar trainings. And the patients monitoring via digital systems would provide a high quality data, and that would be a more comfortable process for the patients. We have prepared a software called Health Disease Management Platform, and that will be ready for use in 2021. So if the blood pressure is more than 180, you have to refer. This is written in the guidelines. And in the system, if the blood pressure is 180, the system will alert that this person should be referred to another doctor, another professional. So we have prepared a screen as if we are talking to the doctor, and this is providing standardization of the quality of the health service. Now, hypertension, cardiovascular assessment, diabetes, and obesity screens are ready. Starting from January of 2021, the family doctors will start using those systems, and we would like them to be used more frequently, and we are changing the logic of the family doctors. They will be responsible of following up the process in regarding those diseases. In the international literature, lifestyle change should be one-to-one going together, the lifestyle change and the medical therapy should continue at the same time. In our country, this is not always possible. For this reason, lifestyle recommendations should be absolutely provided to the patients. So, and these should be monitored by family doctors as well as the dietitian in the Healthy Life Center. In the system at the moment, we do not have a referral chain, so people can come to health centers whenever they want. There is no plan for that. So we are going to change the perspective. Instead of reactive health services, we are going to shift to the system of proactive services. There should be an annual plan prepared between the doctor and the patient, so they will meet according to that plan. For example, if a doctor has 50 hypertensive patients and if they have monitored 30 of them, that will be visible on their own screen. In the year 2014, we have used this system in different cities on an average between 2 and 5 minutes they can complete all the information. The lab analysis in any hospital in the Turkey can be seen directly by the family doctor. While formulating all of those policies, we were also trying to find an evidence about our policies. As you know, in June 2013, together with WHO, we have made an assessment about our service provision about non-communicable diseases, and we have prepared certain recommendations about enhancement of the system. And we were also in the kitchen of the step work for Syrians. Step work is carried out with the organization, the WHO, the World Health Organization.
Kronik hastalıklar ve risk faktörüyle sıklığıyla ilgili çalışmaları düzenli olarak yapıyoruz.
And we are also providing regular system review about the chronic diseases. And we are preparing reports from the registries of the ministry.
Ekonomik yükle, hastalıkların ekonomik yüküyle ilgili çalışmaları
We have completed works about economic burden of the diseases, and with this data, we have informed the Ministry of Finance, and we have persuaded them that the payment for the family doctors, should be changed. We have made a new cohort. We have screened the health registers from 2013 to 2020. We have accumulated some numbers, and we worked about the incidence and prevalence. So we are not saying this as prevalence or incidence. We have tried to make a cohort starting from the health registries. And this has been very important in identifying the processes.
Değerli büyük bir ekiple yapıyoruz. Yani burada
And we
bir
are making this with a team. So all of these activities is not conducted by only our department. We are working with WHO and other departments of our ministry have been working together with us in active collaboration. We believe that it's possible to reach the goals together with active collaboration. As ministry, you have to think 3 times while planning the work. But if your plan is useful, you can obtain very good results. Everything that we have explained, we have presented, we wanted to find out if they are also suitable for the Syrian health professionals. And we have made a need assessment for non-communicable diseases. After me, Dr. Özkan is going to share the results of that study. Thank you very much for listening to me.
Çok teşekkürler Seçil Hocam. Sözü vermeden önce bir kere daha Banu Hocam'a teşekkür etmek istiyorum. Her zamanki gibi.
Thank you. I would like to thank Dr. Banu Ekinci for the presentation because it is very difficult to follow all those innovative developments in your ministry. So I would like to meet you in the ministry after the COVID-19. Now I would like to give floor to Ms. Seçil. Sorry for giving the word at the last row, but we are going to listen to your presentation in an enthusiastic manner. First of all, good afternoon. And I would like to congratulate the new WHO representative. Welcome. And also dear colleagues. And also we have the healthcare workers, the directors in all the provincial healthcare centers. So I would like to welcome you all. So I'm really pleased to be here together with you. We have the students, we have all the residents. So this is a great symposium. Thank you for your efforts in organizing such a symposium. Of course, we have shared the data with the WHO and also with the Ministry of Health, but this was a very, very comprehensive study, and I am very pleased to share the results with you. And thank you for the efforts and contributions of my colleagues. Of course, the migrant health centers, NCDs. So we try to understand the management and we try to make a need assessment survey on NCDs. And first of all, we would like to thank the KFW because they also provided the funding, and I would like to thank each department in the ministry and also WHO and also as the Department of Public Health in Gazi University. We have contributed to this study altogether. Of course, this is a very significant topic because today, we have been trying to fight against this pandemic, COVID-19, as Mr. Ergüder stated, because, during these days, NCDs are important, but due to the COVID, sometimes the risk factors come to the forefront physically because we try to be more active. We try to quit using tobacco. And also there is the stress of the COVID-19. So there are some factors moving towards NCDs. And on the other hand, we need to control the follow-ups for the NCDs. Of course, if we are talking about the migrants and refugees, then we need to focus on additional risk factors. For the future, these outputs, the results of the study will be very beneficial. First of all, as you can see from the title, the aim of the study was to improve the management of the NCD for refugees and migrants. We try to work together for the management. We try to share information, we try to share their experiences, and then we try to make analysis. And then I'm going to share some photos with you. This was one of the first meetings of this study because we were very excited. We came together, and then of course we held too many meetings. And now, after the objective, I would like to emphasize on the methodology. We had a combined method because we had both the qualitative part and the quantitative part and qualitative part. So first of all, we try to analyze the figures because I'm not going to go into the details of this epidemiological methodology, but first observational and then experimental and methodological approach. In the qualitative side, most of the time we try to examine the topic elaborately and we try to receive the comments and observations. So we held focal group meetings, physician, nurse, and also the patients applying to those centers. So we had developed format for those interviews. For the quantitative part, we are